like to show you the next one, and basically here the pitfall was the color. In Spain we have tons of those. Tetracycline staining.
Next time you can keep them.
So he was pretty much the first time, no, that you have to deal with the tetracycline.
This kind of tetracycline discoloration, yes.
And besides that, we have to deal with an implant that was already there in a course. This is the situation, and you can see we have a lot of problems with the soft tissue. And we wanted to make sure that we had some bone below to really support the connective tissue that we were planning in the mesial distal aspect. We wanted to have an idea, the buccal volume, how the bone was related. Unfortunately, I didn't really document the connective tissue phase, but you can see here on the left side, 2 weeks after the connective tissue, everything was done on a tunnel way, trying to place the maximum tissue, but you can see how much collapse I got 3 months later. I asked the patient, I can do another one for you, it will be better, we can maybe grow, that tissue will grow coronally. He was not really happy to hear that, and he said, no, I'd rather, it's already great enough like it is, it's really smaller, so we'll leave it that way. So I placed my provisional. This is how much I could obtain, even though I know that the implant is so close to the root that it would be impossible to have a higher papilla than that. And I decided to bleach the central incisor and maybe do a composite, but the bleaching was totally different color from the rest of the teeth, so we decided to do a veneer. With a veneer, maybe I would be able to diminish the diameter of the root and leaving more space for that tissue to grow if it was possible. Here, the major volume was towards the distal, so I asked Patrick, listen, the pitfall here also is I want to make that the central, the implant is placed a little bit more distal than what it is. So I tried to already, with my abutment, create that emergence profile, but please try to over-contour as much as you can so it looks like as much as possible to the contralateral lateral. So we took a reference, communication is about, hey, this is the color, try to copy that. So we said, listen, in this one is no way you have to come back to San Sebastian. We have some good dinner together, but you need to see this patient.
This you can't create on a certain distance. You have to see the patient by hand. And like we start the first case, you have to analyze the shape, because the shape make everything. Because the color is one, but for me, the most important thing in an anterior region is just the shape, the length, luster, and then the color. So you see here occlusally that there is always, or in this case, a difference between the position of the natural, lateral, and the implant. So normally we have to add some material in the margin. So what does this mean? I have to scarf a little bit to create space, and then always time to discuss to Iñaki how much can I scarf, because we need an over-contoured crown at the margin region. You see the red one, this is what we are going to build up to create more or less the same height as the natural lateral incisor. We did a feldspatic veneer, and I have my reason for that, because when I create a feldspatic veneer, I can create some of these colors, I can play with my value, with my chroma, all this stuff. When I press or a monolithic crown, I don't have to change the chance to change everything. Like I told you, to control the position of the incisal edge, we take some incisal indexes, and in that index we have to create our restoration. We build up the crowns, the position of the lateral incisor on the implant is very important. We have to flap it out to see how much approximal area there is on that kind of implant crown. And normally, then you can try to make your color. Because the pitfall was, it was a tetracycline discoloration, and then you have to check it. You have to, your staining material, you paint some blue, pink, grayish, brown to create the cervical area in the most dark color I ever have made in my life. So we don't see that so much in Belgium, but in Spain it's more or less the average, the normal way. And then actually...
It's not the average.
Yeah, that's correct. Then if you make an feldspatic veneer, normally if you put your feldspatic veneer in your furnace, it doesn't fit any longer. But I have a trick. I take the firing paste, I put everything into the feldspatic veneer, I put it on my tray, and then I fire it. And the rim, the fit will stay after the firing. And this is very important, otherwise you don't have a good fit and it's the bad fit. So if you have your color, because you can check it in the patient's mouth, you can check it and you fire it. That's it. You don't need a vacuum in this case because you haven't done a minor correction with dentin colors or something like that. With our gold
one of the good things about having the fire paste is that it allows the dentist to really be able to try the veneer.
That's correct.
And come back and do any changes.
Yeah, that's correct.
Maybe
I've forgotten this. Thank you.
Maybe
that's correct. Now you can
something
check
that is not done too often by the technicians. They think that there's no way that they can go back and recheck it.
That's
so
correct.
Minor adjustments can be done like we did in this case.
You see, with gold spray, you can check the luster, everything, because this is very important in such kind of anterior cases. And now you can see how many ceramic we have built up on the margin region. You see the red line is built up to the buccal and apically. So this means that we need a fine structure ceramic. This means that it's very homogeneous after the firing, because if you compare this fine structure ceramic to conventional ceramics, there is a big difference for the homogeneity. You can see this directly as a trained eye. This is a fine structure ceramic or not.
So basically what you see here is that the abutment was not correctly done. This is the difficulty of the game.
Yep.
If you use the abutment from day first in your protocol, this is what can happen, is that your abutment is not far out enough.
That's correct.
And then you have to compensate it with your crown or redo the abutment.
Yep.
So this is the pitfall of this case.
Yep.
Then whenever you face, it's Champions League, is more difficulty because you need to have a lot of knowledge about how the tissue is going to be displaced and where you're going to get. So this case was really tough, but this is in essence what happens in the clinic if you play that game, providing the abutment, the final abutment from day first. So for me, it's not such an important. What is important is doing the connective tissue graft. You can maybe use a provisional composite to make sure which would be the ideal of the emergence profile and then come up to the final abutment, for example. I don't think you lose any of doing that. So this is the try-in, and you can see I had to use some whitish color in order to come up to something that was acceptable, because value was a little bit tricky in this case. And we went through all the veneer preparations once we tried it, and then we cemented in the same way that I explained you before. The abutments are unscrewed, tissue is cleaned, put it back, and 2 independent cords to really come up to the final work. This is about a week or so after the placement, and you can see how the tissue is kind of creeping back, and this is due to the central incisor, and this is about a month. You can see how the tissue has been moved around, and obviously within a year this will be a great situation. You can see the close proximity of the implant that was already placed in there from another colleague. So let's show you the last case, and with this one we will be finished. And I guess this is a challenge. It's a challenge for you. It's a challenge for me. It's a challenge even for the patient. Really middle high lip line. She has had that bridge just a year ago. She's not satisfied. Really difficult case to complain. Every time that we have to bring pink tissue towards the incisal edge. So you can see the difficulty here as far as proportion, as far as tissue height, as far as uneven gingival levels. So you can see she has everything. Those are the type of cases that really we could not come to a different situation without orthodontics. And with orthodontics, we decide to extrude the adjacent teeth in order to maintain the adjacent bone level and come up with an implant on a central incisor to really be able to provide better stability in that area. We did some other implants on the posterior, but we are not going to focus on that. So you can see the tissues on the lateral incisor from the top to the bottom, how much we were able to achieve and level the soft tissues from where we were to the provisional restoration. You can see here the tissue is still maturing. The provisional already provides a huge difference only by extruding two teeth. The difference. The problem now was to decide which design, as far as the implant placement, how I was going to approach this case. I don't know your experience, but open a flap on a place where you have extruded the adjacent teeth, you are always going to lose some. So we decided to be minimally invasive and do, even though my implant was going to be quite high, a little bit palatal, we decided to go ahead and place the implant no matter the difficulty of the case. So this is the before on the left, and on the right after the extrusion of both the central and lateral incisor. This is her smile before and after. So the orthodontist, by the way, was done by Domingo Martin in San Sebastian, and we decided to do a noble guide in order to avoid the opening of the flap. You can see the bone was just on the edge, but we were able to come up with a nice placement. Maybe the depth was the issue on here, but you can see what we were able to achieve. I would like to show you this case 5 years down the road, and you can see the connective tissue graft that was performed the day of the implant placement. And the abutment was virtually designed, and we come up with this result as you are seeing. The big issue that I was confronting was the dissimilarity between my abutment and the implant. And you can see that this was really reflected through all the process of my treatment with the scalloping of my two teeth. You can see that the central incisor on the teeth had higher scallop than the scallop on top of my implant. And you could see that I was already on the process of taking my final impression, then where I decided that it was too late to come back to orthodontics because, first of all, the patient would have killed me. So I would say, well, another option is I'm going to call those guys and I will call my technician and ask him to do the same emergence profile on both restorations, and to provide me with a copy so I could, in a sense, have an idea where is going to locate my finishing line. So we are talking now about final an edge type of finishing line. But the most important for me as a dentist was to have the same emergence profile horizontally coming out from both abutments at the same level. And this is what I asked him, Patrick, I know that you have never done this, but no. I want you to ask you to make a copying, and with that copying I want the same diameter of both central incisor, and I want just to grind the buccal aspect to come up with two abutments that have the same diameter on the facial aspect. In this way, my two crowns will come up from the tissue at the same level. Obviously, the difficulty is here, never touch the bone. If you touch the bone, you will create a recession.
Yeah, the big problem in such kind of cases is if you leave it like that way and you build up two central incisors, and the two central incisors are, for us, the most important teeth aesthetically in the patient's mouth, then you have two different colors. Because otherwise, on the abutment crown, you have to build up, and on the other natural tooth, you have to reduce something. This means that you always have differences in value, and you can't do this when you correct, but you don't correct the natural tooth.
The other issue that we should say here to the dentist is if they are already planning on doing that, is to create a wide and longer, longer margin shoulder in order to allow any kind of rest into the coping once you are doing it.
That's correct, but sometimes then have you a shift apically, and this doesn't make sense. We would like to have the same level on the implant crown and on the natural prepared tooth. So we created some copings, just copings in the resin, and we reshaped the outline, and then we sent this coping to Iñaki, and he did the same in the patient's mouth. So you can see here on the left side, the reduced, this is what we have ground away.
So this is maybe the timing is not the correct one, because the correct should have been to have it done before.
But we have to talk about pitfalls. Huh?
Yes, but this was a problem that I encountered because, I didn't really pay the attention about this situation because my provisional already fooled me. So I had to go forward with the reconstruction, so I decided, listen, I do the coping, I place the provisional, and I will try my bisbake, but I will wait until the tissue comes back. So we waited 3 months and see how the tissue came while he was doing his bisbake.
Over time. This is just what we have done in this case. It was based on one implant crown, and all the rest were small bridges, all noble procera zirconia, because we would like to have them all in zirconia, because we feel, at least in our hands, we have a good protocol to handle actually zirconia and layered zirconia.
So basically, you need to anesthetize the patient, kind of deflect the tissue, and really to come up with something like a kind of a platform shift in order to really come up with two abutments that have the same diameter and will support in the same way the tissue, and create the symmetry that we are looking as far as the emergence from the finishing line into the tissue support. So 3 months later, you can see how the tissue came back, how we were able to really come up with something that looked the same as far as the scalloping. And this is the bone remodeling, but you still see that the bone on the adjacent teeth is the one that is holding everything together. And we'll show you, now we were ready, I was ready then to come up and finalize the case and cement it. And this is the situation for the upper arch, where we started, where we finished, and the situation, top rehabilitation against lower natural teeth. And you can see here, before and after, 5 years down the road, and you can see 5 years post-insertion, how the tissue has been holding pretty well in the same place than where we left it. So thank you very much for your kind attention. Thank you for your good work. Thank you very much
for the collaboration.